All right, Janet, whenever you're ready, you can go ahead.
Okay. I'm Janet Smith. I'm out here in Pendleton County, working as a diabetes care specialist. And I find patients come my way on various therapies, and had some important questions on a particular patient that was new to our clinic last fall. So this gal is 54. She is a morbidly obese woman, has had diabetes since age 4, identified as type 1. And she was seen by endocrinology in Virginia, over in Charlottesville, Martha Jefferson Endocrinology, prior to coming to our clinic. And when she came to us, she was already using a Tandem T-Slim insulin pump and on Dexcom G6 CGM, and operating her pump in the control IQ mode. She was also taking Victoza 1.8 milligrams daily. And when she was seeing me for the very first time back November the 8th, she was requesting assistance with prescriptions to get her pump supplies and CGM supplies. A prescription for Humalog vials had already been provided. When she asked about Victoza, I was declining to renew that therapy due to it being off label for type 1, just not comfortable with it at that time. And she, in fact, said she wasn't sure it helped very much anyway. So these are, we did some downloads of her pump, and we can't get Dexcom reports separate from her Tandem T-Connect reports, but we do get a good bit of data from her T-Connect. And she was using about 153 units of insulin a day. Interestingly, she was getting about 78% of her insulin is boluses and only 22% basal, which is kind of disproportionate. Her average glucose was 138. She was in target 76% of the time, above target 19, below target 5% of the time. I'm always trying to get the below target time under 3%. So I was a bit concerned about her having too, excess frequency of low blood sugar going on. But she would say, oh, I don't mind having lows because I can eat my sweet snack foods and drink my regular sodas the way I like to. So we had some issues right away with her eating behaviors. Anyway, she's had a long history of obesity, and unfortunately, since she's been under our care, she's gained 21 pounds in this 5-month time period. She has indicated that her appetite has picked up since the Victoza was stopped. She really doesn't know how to do portion control, seems incapable of it. And she's told me that when she took Victoza, she felt sick if she ate too much. So, that helped to keep her a little bit more controlled, because she would try to avoid feeling sick. But now that she's not getting Victoza, she has nothing to hold her back from eating excessively. At least this is the perception I have. When I saw her recently, she requested a restart of her Victoza. I talked with Dr. Rexroad about it, and given that it was prescribed by an endocrinology provider in the past, we thought, well, we'll see what happens. We'll prescribe it and see if it's covered by her new insurance, which is a West Virginia Medicaid plan. So we put the order through and got a denial stating that it was off label for someone with type 1 diabetes. And she's continuing to press us to try to appeal that denial to see if we can get it for her. So one of my important questions was going to be, do we pursue that? Should we pursue that? How could we pursue getting approval for Victoza or any GLP-1 receptor agonists for someone who has a diagnosis of type 1 diabetes? I included here some information about her pump settings. I lowered her basal rate from 2 units an hour to 1.5 units an hour between midnight and noon back in January. And despite that, her time below target has actually gone from 5% to 15%. She has been too low, too much. She doesn't really use her bolus calculator built into the pump appropriately in my view, she prefers to guess on her insulin requirements. This doesn't help the situation. Some of these lows are being driven by the patient's choice. So anyway, you can see those pump settings. Physical assessment's pretty ordinary. She's had some amputated digits on her hands, and I actually cannot recall what the cause of those amputations was. She has bipolar 1. She has already had coronary artery disease requiring CABG at her young age. She's got hypertension, hyperlipidemia, neuropathy, vitamin D deficiency. We have sleep apnea on her problem list, and when we referred her for a sleep study to establish her here locally, she didn't keep her appointment and has not rescheduled an appointment for a sleep evaluation. So sleep is not particularly going well. She does have some issues with lower extremity edema, psoriasis, agoraphobia, hypothyroidism. Her exam looks pretty normal, as I said, other than the obesity and some amputations. And I did not include any other labs beyond the A1C that was done on the 8th of March, 5.9, because they were all normal. And she's fairly euthyroid on her current dose of levothyroxine. So I am wondering if she's appropriate for a GLP-1 receptor agonist, and I'm wondering if she's really appropriate for being on an insulin pump. So I wanted to ask Dr. Turner or anyone else in the team what their thoughts are.
Sure. So I think this patient would definitely benefit from a GLP-1. I actually have a couple of type 1 diabetics that are on GLP-1s. And I think with this patient and the appeal, you could make the argument for not only, it improved her sugars previously, if it did. I know she was following elsewhere, but if her sugars were better while she was taking it, which I often find they are, that would be one thing. The morbid obesity would be another that she could benefit from. And then the third thing that I noticed is that she had a coronary artery bypass graft. And so, I would even make the argument that those medicines are known to show decreased risk for secondary cardiovascular disease prevention. And so that's also why I would, not necessarily the Victoza though. So that one has not been shown to have that benefit. But as you were presenting, I was thinking, wow, this patient would be good for Ozempic, would be a good option. I don't think that Mounjaro would be covered with the West Virginia Medicaid, but I definitely think Ozempic would be something to try for.
Okay.
And then if they say no Ozempic, but you can do Trulicity, that would be fine too, because you get the primary and secondary risk reduction with the Trulicity. But yes, I agree. It may be difficult. Honestly, the two people that I do have on it, I feel that one of my type 1s that's also on a pump that I was able to get on Ozempic was on one insurance, then went off of that insurance onto something different, and the insurance would not let me use it. So, there is a chance they still deny it, sadly.
Now, I wondered if you had any particular experience with Medicaid of West Virginia, and how to plead the case.
A little bit to that, Jen.
I was gonna say if you were on here.
I totally agree that I think this would be a great candidate for GLP because of all the things that Dr. Turner mentioned. Unfortunately, West Virginia Medicaid is cracking down a little bit. So it may be difficult. Even in type 2 diabetics, they're requiring an A1C above 7 for initiation, which is not evidence-based at all. So it's kind of frustrating, but I think getting off-label use maybe even just that much harder now than it was previously even. So I think it may be worth doing the appeal because you have evidence to show that she was on these medications before and they were beneficial. So maybe they will approve it, but I don't want you to get your hopes up too much because they are cracking down quite a bit on off-label use of these medications.
Right. But is she using the pump as a license to eat?
What's that?
Is she using her insulin pump as a license to eat?
My patient.
Is this patient? Yeah.
Oh, well, I think she's fine to use the pump. Well, I mean, I agree with you. It should be more of a 50-50 split, which I know you know that too, but, and she's what, 70-20 something or 73-27, with bolus being predominant. Yeah, I mean, I think that that's not appropriate. And I would even tell her, you know, she's not really getting the benefit from the pump. It's very skewed. So here's what I think. Either way, even if you used multiple daily injections versus pumped, there's a chance that she can give herself as much as she wants. So, you know, the pump would at least be a way to, if she gives herself too much, it would suspend the basal. So, you know, if we're thinking about benefits, that might be one benefit over the, you know, multiple daily injections. But, you know, I agree. I don't think that's appropriate to just eat what you want and then bolus as much as you're eating for. When were the majority of her lows happening? Are they still overnight?
They're mostly during the daytime.
Okay. I would even use that as in my back pocket to help try to convince her, you know, if they're happening during the day, it could be because she's giving herself way too much insulin. And yeah, I mean, it's really, unfortunately, they're cracking down on the GLP-1s, but it would be great if you could get her that too. Maybe even other medicines for appetite. You know, some of the other anti-obesity medications might even help with keeping her, if she's somebody that likes to steer on the side of binge eating. I don't know, I don't want to assume anything, but I know you said she likes to eat a lot and the GLP-1 helped with that, but you can always consider one of those medicines as well if we can't get the GLP-1 covered. That was a really long-winded answer. I don't know if I answered your question.
I thank you. Yeah.
Sure. You know, as far as terminology, I usually ask, you know, one of our folks that does prior authorizations, but if I were wording the letter, I would say exactly what you've told us. Or, you know, for instance, with my patient that was a type 1 that I had to write an appeal letter for, that's what I said. I said, sugars were better controlled. She struggled with obesity. This patient that I have actually had a bariatric surgery procedure, and then she was stalled in her weight loss. And so I also stated that in my appeal letter. And then I would throw in the coronary artery disease, you know.
Does it help at all to comment about, you know, patient having to increase insulin usage without the GLP you know, as an active drug, and that it's contributing to her worsening of her obesity? Does it help to even comment about obesity in these letters?
I would think so. Hugh, what do you think? I would say it, but
I think any supporting information you can put in the letter is going to be beneficial and won't hurt. So I think adding that in would be great. Whether or not they take that into consideration, I think it depends on whose desk it ends up on, but I think adding that would definitely be beneficial.
I was curious about whether or not you should talk about her her bipolar disease and the fact that that makes self-control more difficult, and in fact some of her medications, I mean, she's not on any of the antipsychotics that are known for obese, you know, making people eat, but I just feel like that's an important piece of this, is that her mental health may not be allowing her to take as good a care of herself as she would otherwise.
Again, I agree that that's a piece of the puzzle and further supports the evidence. Sometimes these places are black and white, and it's if you don't make the criteria, it's no matter what. So I think, like I said, anything you can put in the letter to support it would be helpful.
yeah, I don't know if her mood has worsened with the weight gain, but you could even say that if that has happened, deterioration of her mood as a result of the weight gain that she's had since the medication was stopped or something like that.
That's valid. So thank you.
Yeah.
Mhm.
And we are starting to study these medications in type 1 diabetic. So they're not indicated right now for anything in a type 1 diabetic, but whether that's glucose control or weight loss in type 1 diabetics in the future, that might change. So there's studies ongoing for that.
Mhm. What about Simlin? Would that be of any use in this patient?
I don't have much experience with it, but it is indicated. So it may have some benefit if that's an option you want to consider.
I think Dr. Barghouthi, I think she may have had a patient, so she had to log off. I think she has a type 1 that's on Simlin, and they do really well with it. So maybe
I think if we got a denial on Ozempic, the GLP-1s, I could at least pursue that.
yeah, I think that would be a reasonable. I'm pretty sure that that's one of her patients, but yeah, can certainly check on it.
I'd like to find a way to reduce her insulin usage.
Yeah, it sounds like she's had quite an increase. And then that's also not helping her weight either, as I know everyone knows, but more insulin means potential for more weight gain. So I think it's kind of a snowball effect, sadly.
Thank you very much.
You're welcome. Thank you for the case.
Yeah, thank you so much. It's a great case. Really appreciate you submitting it. And I know I'm patient type. I'm patient. I'm not a doctor, but I could ask my doctor how I got on Ozempic because I wasn't. There's a couple of times I tried to and it wasn't covered. And I'm not diabetic. I have insulin resistance and I was unable to lose weight. And I tried so many avenues and I have depression, anxiety. When I started that medication, I know there's like a lot of studies that say there's no correlation, but I gained like 30 pounds. And with my PCOS, and that was really difficult. And I did everything and I finally got on Ozempic. So I could ask her what she did. My cholesterol is higher. I don't know if she included that to get the medication covered or because of my depression impacting like my mood with the weight gain. That's a good idea, I think, but I could ask. I'm happy to ask my doctor, Janet, because I don't know how she got it passed, but it finally did.
I'm taking tips from anyone.
Yeah, so I'm happy to be like, hey, what'd you do? What's your secret? Because it really has made a difference in the, in my outlook and trying to get better. So, I mean, I think your patient does need to do the work too. It's not like a be all answer. You have to do other things, walking or whatever she can do. Like, I don't know, but
I'd like to get her really plugged in with our behavioral health team here.
Yeah,
because I think she needs coaching and support to make changes that are hard.
They're super hard, but yeah, we really appreciate the case and your time today. And we really appreciate Dr. Turner and you for your input. We can't thank you enough. So thank you guys. Yeah. All right, Dr. Turner, would you like me to share my screen for you today?
Sure, that's great.
Yeah, absolutely. Give me one moment.
I might be able to bring it up if that's, I don't know how most people do it, but
whatever you're most comfortable with, I can always give you like capabilities with my sharing to also advance, but I am completely fine doing it.
Oh yeah, if you want to do that, that way you don't have to advance it. I can do it.
That'd be great. Hold on. This is a new thing that they're offering, so I'm trying to figure out. This is so strange. Mitra, it's only like giving me access to like, I don't see her on the list of the slide control.
Really? That's so interesting. Do you maybe have to make her co-host? I'm not sure about this new feature that Zoom is doing.
Zoom, what are you doing to me?
Wonder.
I can just do it this time around. We'll play with it. I'm so sorry.
Oh, that's okay. Let me see if it'll let me do anything.
It's been crazy. I made you a co-host though, so you could do so as well.
Okay. Yeah, I've tried to click on the presentation, but it won't let me.
You want to do share screen? Try that.
And pull it up on my end?
Yeah, and see if that works. I do apologize. I was trying to do that cool.
That's okay.
Slide control thing, so you don't have to worry about pulling it up yourself. But it was...
Let me open it on my iPad first. If everyone doesn't mind bearing with me for a second. Let's see. Okay. Let me see if it'll let me share it now.
No worries. If not, of course, I'm more than happy.
Yeah, that's true.
Okay. Can everyone see that?
Yeah, that's fancy.
I'm gonna try opening it here. It's on my iPad, so.
That's cool. Oh gosh, I can see my face.
Okay. All right, I think I've got it. Can everyone see that?
I can.
Okay. All right, I'll go ahead and get started. So objectives for today, I'm just gonna, I think a year or two ago, Dr. Barghouti did a male hypogonadism lecture, but I was gonna review some of that today and, just familiarize everybody with some of the causes of hypogonadism and why it's important to appropriately work it up. And then we'll review some common preparations of testosterone replacement, and I'll review, the lab monitoring while on therapy. And a lot of times with testosterone replacement, it really just depends on which formulation that you're on in order to determine when to check the levels. So I'll go over that as well. So possible signs and symptoms of low testosterone. Some of these are really non-specific. Fatigue. It seems a lot of times like many people that we see in a day-to-day clinic visit are having fatigue. But I was trying to clear that away. Sorry about that. I think, let me move that. Okay, there we go. So hot flashes, enlargement of breast tissue, those are a little more specific. If people are having infertility and erectile dysfunction, I really start to, not that I'm not listening before, but that's really when I start to pay attention and see if I need to check the testosterone. So I don't recommend checking it for fatigue, depression, those really non-specific type symptoms. But I know I mentioned this on the last slide. If they're having erectile dysfunction, low libido, enlargement of the breast tissue or gynecomastia, then I really start to think, let's see what their testosterone is. Certainly if they have known pituitary disease, or if they've had prior, pituitary surgeries or radiation, definitely be thinking about the testosterone. Or if you have a young male patient that's had a low trauma fracture, that should also be a consideration. So when is the best time to check testosterone? I will say this is probably one of the more important slides. A lot of times we'll get referrals and the testosterone is checked at 2 p.m. The best time to check the testosterone level is at 8 a.m. after the patient's been fasting for about 10 to 12 hours. And I usually ask them to try not to eat something very high in fat or greasy meal the night before. Now, if they're a night shift worker, it gets a little bit sticky because, you can't check it at 8 a.m. That's really their nighttime. So that presents its own challenge, but the best time to check testosterone, it peaks at 8 a.m., between 6 and 8 a.m. So have them go in fasting 10 to 12 hours and check it at 8 a.m. That's the best time. If they are a night shift worker, sometimes I saw a patient that was a paramedic and they did some night shifts, some day shifts. So I'll wait until they've been on a day shift for a few days in a row and have them check it, the third day they've been on a day shift at 8 a.m. So the later the day in the day that it's checked, the lower it's going to be. So you're really going to get a falsely low reading. You expect that it drops off throughout the day. So say you check it at the appropriate time, you get a low result. Then what? Well, the next step should not be to start testosterone therapy. Okay. You want at least 2 values that are low before you start someone on therapy. You know, sometimes if a person's just getting over an illness, they may have had just some slight hypothalamic pituitary gonadal axis suppression. And so the testosterone's low in a normal setting in that case. And then it can, it can recover after that. So you want to repeat another testosterone on a separate day, 8 a.m. while they've been fasting. Another big reason why we recommend this is a lot of times we'll see patients that have been started on therapy, and then a lot of times we'll have to talk them into holding it so that we can retest them and try to determine the etiology. So that's really important. So here is what I order on a separate day. So when, say you've got one reading that's low, I tell the patient, we're going to repeat some labs. This time I check a free and total testosterone. That's what you would have checked before too, but you want free and total. Something called a sex hormone binding globulin level, and I'll talk about that more in a minute. FSH and LH, which are the 2 pituitary hormones, and that will help you determine whether this is a primary hypogonadism or a secondary hypogonadism. A prolactin level, and then a TSH and a free T4. Those are usually what I go to next. Okay. So what's sex hormone binding globulin? Why would you ever need to order it? So this is a protein that's made in the liver and it binds to sex hormones in the body. So, you know, a lot of times we'll see these patients that have a low total testosterone, but their free testosterone is smack dab in the middle of normal range. And that can happen when you have decreased sex hormone binding globulin. And so if I see, you know, that they have a low initial testosterone, I'll check that SHBG with the next set of labs so that I know which testosterone level to really trust. So when you look at total testosterone, I'm really proud of this because I feel like I can't make any diagrams on PowerPoint, and this took me longer than I'm willing to admit to make. But so when you're looking at total testosterone, it's made up of sex hormone bound testosterone, albumin bound testosterone, and then free testosterone. The free component is quite small, as I'm sure you see here. But if you have a lower sex hormone binding globulin here, then more of this or less of this is going to be bound to sex hormone binding globulin. And so your free testosterone level will be higher than 2%, if that makes sense. And so in a case where someone's sex hormone binding globulin is very, very low, then this free testosterone is more reliable than the total. The total is going to look falsely low. And then I just put here, I don't generally check a bioavailable testosterone, but if you ever check it, it's just including the albumin bound testo and the free testo. And please, someone chime in if you have any questions at all, and I'll explain further. I just put these are tables that are in our Endocrine Society guidelines for management of male hypogonadism. And this is just for reference. You can see that some of these conditions that are associated with decreased sex hormone binding globulin, the big 2 or few that I'll point out here, obesity is a really big cause of low sex hormone binding globulin. And so, you know, I know we see a lot of patients in this state that are obese. And so this is why it's really important to look at. I can't tell you how many people I see on a weekly basis where I check their labs and they, you know, the total testosterone is a little bit low or low normal, and the free is smack dab in the middle of normal range. So this is important, and diabetes also very important, and then hypothyroidism, untreated, of course. And then conditions that have increased sex hormone binding globulin concentrations, that would be, you know, things that can affect the liver, hyperthyroidism. I won't read you this whole list, but estrogens is also an important one. So let's talk a little bit about the possible etiologies of hypogonadism. So I know this is small. I'm going to go to the next slide, but this is a really good reference tool on UpToDate for evaluation of a male that you think might have hypogonadism. I wanted to put the whole thing in here, but if you just go to male hypogonadism, this figure will be one of the things that's in that article. But here's the image in a little bit bigger way to see. So you have to have clinical suspicion, of course, and then you're going to check a testosterone, say it's low. Well, if it's normal, you don't need to do anything else. If it's low, this gives you a nice breakdown of what to do next. These were the labs that I talked about. I know I added a couple of other labs on there in one of my prior slides, but it's a nice way to kind of help you separate things in your mind. And I'm going to go through each primary and secondary hypogonadism, but just know that this is available on UpToDate and my slides, of course. So if you need to reference it in the future. So what is primary hypogonadism? When you're talking about anything endocrine related, anytime it's a primary hypothyroidism or primary hypogonadism, that's always the organ where that hormone is made. So primary hypogonadism means your testosterone's low and it's in the primary organ where testosterone is made, which is the testicle. So in these patients, everything up top is working. Everything in the pituitary gland is working, right? So what do you expect those to be with a low testosterone? High, because they're trying to get the signal down there and then the testicles just aren't making testosterone. So this is a testicular problem. And if you go back on this slide, you can see, I know I'm pointing to my screen, I should use this cursor, but you can see here that the next recommended step is a karyotype. Well, why is that? That's because we're looking for Klinefelter syndrome. Klinefelter syndrome is basically where you have an extra X chromosome, maybe even more than one in a male patient. So they could be XXY, etc. So that is a big reason why they recommend the karyotyping. And then orchitis, certainly things that can affect the testicles, any prior trauma. One of the big things that I'll ask patients if they have this pattern of labs is if they were ever born with undescended testicles, because even if they had surgery to pull the testicles down into the scrotum, they could have some testicular damage and they may not be making testosterone or even sperm. So secondary hypogonadism is a problem with the hormones secondary or responsible for stimulating the primary organ. So this would be more of a pituitary type of issue. So the FSH and LH will be either normal, which is inappropriately normal, or they'll be low with a low testosterone. This can have a number of different causes, and this is what we see more commonly than primary. At least that's how I feel. And you can have congenital causes and then acquired causes. Congenital causes, Kallman syndrome. If everyone remembers this from training, this is where patients, not everyone, but some patients can have the absence of the ability to smell. And then hypogonadism, of course, and it's just a GnRH deficiency. And then acquired would be things like radiation to the pituitary or a pituitary mass, or even some medications like opioids and steroids high dose steroids for a longer period of time can kind of suppress the axis. So those are the big ones. So ideally, when you're working this up, if you've gotten this far, great, but we are more than happy to see patients. So I think when Dr. Barghouti did her lecture, she said refer to endocrine after that second testosterone is abnormal. But you can do some of the workup that I even mentioned here before you send them to us. But our big thing is we want to see these patients before they get started on testosterone in an ideal setting, because my biggest concern is, do they have something in their pituitary that I need to worry about? And that's oftentimes why I'll recommend that they go off of testosterone for about 8 weeks so I can recheck them. Because say they have a whopping pituitary adenoma that's just shoving on all the pituitary cells and inhibiting the secretion of FSH and LH. Well, we won't know that unless we appropriately evaluate it. So when should you start testosterone therapy? So I know I just kind of said this, but not until the diagnostic testing is complete. So the goal when you start someone on testosterone therapy is to raise their serum testosterone concentration. This is, of course, the total. You want to raise that into the mid-normal range. our guidelines say 350 to 600. Some different sources will say 400 to 700, but in that mid range. And I'm going to talk today about some of the options. Some of these options I've actually never used, and I'll tell you which ones they are. I kind of preferentially choose the IM or sub-Q injections. So I'll start with the IM first. So that's testosterone, enanthate, and cypionate. So they don't really have any brand names that I've come across. When people use these injections, it's a deep intramuscular injection. They can give this in the thigh or the buttocks. Those are the two main places that we recommend. I typically dose once a week because I find that it keeps the patients a little more leveled out. When they go to the 2-3 week cycles where they give it one injection every 3 weeks, the testosterone levels in the body just drop off and they tend to feel poorly right before they're due for the next injection. So typically what I start with is 50 milligrams intramuscularly once a week. I think it's a good starting dose. You can always go up. When I titrate up, I typically do it by about 25 milligrams, depending on what their testosterone is. I have had cases before where they just need it tweaked a little bit. So I'll go from 50 to 60 milligrams once a week. And the best time to check a testosterone level, you want to catch the peak value in these types of situations. So at the midpoint between injections is when I recommend. I do not recommend checking it just before the next dose because you're really not going to get an accurate reading. You're going to get the reading when it's already started to fall and you're about to give the next dose. So I check the peak level at the midpoint between injections. So the next one I'll talk about is intramuscular testosterone and decanoate. I have not used this. This is it's very long lasting. I don't think it has a brand name, although Q, if I'm saying that wrong, you can chime in, but I did not find a brand name for this one. I have not used it, like I mentioned, but they typically recommend 750 to 1,000 milligrams intramuscularly with a plan to repeat the first dose. This is just when you initially start it. When you originally start it, you're going to give a dose, and then in about 4 to 6 weeks, give a second dose. But then every other time you dose it, it's about every 10 weeks. So it's longer lasting if people can't follow up. I didn't put side effects on each slide, but this one has a side effect that other testosterone formulations don't. And it's for I think it's an oil embolism. And so, that's, I know, scary to a lot of patients, but I personally have not used this. They recommend checking testosterone level after the patients receive 3 total injections, just so you know that it's a steady state. And they recommend doing it at the midpoint, so the 5-week mark. The next one is subcutaneous testosterone injection. So this one's almost, I would compare it to insulin. It's given on the stomach. You can also do it in the leg, but it's a subcutaneous injection. And I believe it's a single-use pen. The brand name is called Xiasted. I only have about one, maybe 2 of my patients that are on this. And it's similar. It's not a 1-to-1 conversion between intramuscular and subcutaneous, but I typically start with 50 milligrams once a week for this formulation. And same thing, when you're going to check the levels, you're going to check it at the midpoint between injections. I should have brought the pen in here. We have a sample pen I could have shown everyone. I meant to put pictures of everything in the slides, but I didn't want to crowd them all up. So the next that I'll talk about is topical testosterone. I took this, a portion of this table from Up to Date because I figured it was just easier than me typing it all out. It's just cleaner to look at. But there's a number of different brand names. There's Androgel. That's probably the most common. And I actually have, so there's Androgel that's applied on the shoulder area. Usually do start with 2 pumps a day. It really just depends on which one you're using, and I won't read through each one, but they have nice initial dosing guidelines on the Up to Date page. The transdermal solution, I actually had one patient on that. It's almost like an alcohol-based solution, and they put it in the armpit, basically. And the patient I have on it seems to really like it. So of course you have to worry about with any of these is just skin irritation. The other thing I'll tell you about these formulations, really have to be thinking of who else is in the house. So if you have a man that you're seeing that's thinking about switching to it, but he has young children, probably not the best option unless, you know, he's going to make sure he puts it on, wash his hands really good. But, you know, anybody that could potentially touch the arm, it could be transferred to. So when you use testosterone topically in the gel or the solution form, the best time to check a testosterone level is about 2 to 8 hours after they apply it. So if you have a patient that is on one of these formulations, what I would recommend is give them a time in between this 2 to 8 hour range. If they check it one day at the 3 hour mark, and then the next time they get it checked, it's at the 7 hour mark, the testosterone value is going to fluctuate. So I try to get them to be a little bit, you know, pick a time 4 hours after the application and get it checked around 4 hours after each time. The next option is a transdermal patch. So the only brand name we have on the market is Androderm, and that's one patch every day. The usual starting dose is around 2 milligrams, but the typical dose is anywhere from 2 to 6 milligram patch per day. You're not supposed to combine them. So say you want to up their dose to 4 milligrams, do not use 2 milligram patches. Really can't tell you why. That's just what the company recommends against. This is a little bit different. They recommend checking the testosterone about 3 to 12 hours after the application. So oral testosterone, I haven't had a lot of people want to start oral testosterone. So as a result, I don't have anyone on it. I know a couple folks in our clinic have some people on oral testosterone. But typically it's a twice a day dose. So that would be a downside, especially if you have people that are not great with taking medicines. They're going to have to remember to take it at least twice a day. One of the formulations, and it might be the oral testosterone that should say undecanoate, but that one I think you can take 2 to 3 times a day. So when you take these oral formulations, it's recommended to check a testosterone about 3 to 5 hours after they eat a high or a fat containing meal. Nasal testosterone, again, I don't have anybody on this either, but it's called Natesto. The dosing for this is also it's multiple daily doses. So they recommend that you do 1 spray into each nostril. So that's a total of 11 milligrams 3 times a day. So the total daily dose is 33 milligrams. And I didn't see anything on their website about titrating that. I just thought it would be good to bring up to everyone's attention, but it didn't look like they had any guidelines on titrating it. And that's why I went to this site, because I've never used this one personally. Testosterone pellets. So this is, the brand name is Testapel. We don't do these in our clinic. They're a little bit hard to regulate. You know, it's a procedure that requires a sterile field because they have to be typically placed by someone that's had some training. But they're pellets that are implanted into subdermal fat. They're either in the lower abdomen, the buttocks, you can put them in the thigh. And they say the typical dosing is 2 to 6 75 milligram testosterone pellets, and they get changed every 3 to 6 months. So there's not a lot of data for the testosterone pellets, and they're not highly recommended by endocrinologists just because of the paucity of data, and we have better options. And they require a little bit more. I mean, you have to go in and have these placed, and those have risks of their own. But they recommend for this to check a testosterone at the end of the dosing interval. So right before you're due for the next implant of pellets. So when you have someone on testosterone, what labs should we monitor and when should we monitor them? So in the first year that you start someone on testosterone, we check a free and total testosterone every 3 months, just to make sure they're on the right dose and they don't need it adjusted. And I also, along with that, check an H&H because I want to make sure they're not developing polycythemia. And so, if for some reason their hematocrit starts to rise, then that's a reason that the dose needs to be adjusted, decreased. So then every 3 to 6 months, I'll also check AST and ALT. And like I said, after the first year, you can space this apart. You have somebody that's stable, you can start checking H&H, testosterone every 6 months instead of 3. And then yearly, they'll need a lipid panel and an A1C. The reason there's an asterisk beside the PSA, so the prostate specific antigen, not everyone needs this. If you get a patient that comes into your clinic that has hypogonadism and they're 21 years old, that's not needed. I know that, the guidelines are a little bit different between societies, but our endocrine society recommends a PSA for men that are going to be on testosterone therapy that are between the ages of 55 and 69 for just regular risk male patients. Now, if they're a higher risk male patient, and the two things that make you higher risk is either a first degree relative with prostate cancer or African American males, they start getting screened from ages 40 to 69. So that's why I wanted to at least mention that. And remember, the goal is to raise the testosterone concentration into the mid to normal range. So 350 to 600. If you're ever checking this and you get a really wacky reading, either usually it's really high, I always check with the patient. I'm thinking, when did you get this in relation to when the dose was given, just so you can make sure it was timed appropriately. But usually if it's too high, then unless they drew it the day after they gave the dose, I always decrease the dose. So contraindications, some of these are not absolute contraindications, but contraindications to testosterone. If you have a male that's planning fertility, and I feel like maybe I should have included this earlier because this is a huge thing to remember. If a male is going to be started on testosterone, we always first have to assess whether they want children or not, because when you give exogenous testosterone, you can actually decrease their sperm count or the ability to make sperm, which sounds really backwards, but if the testicles themselves are producing testosterone, that helps stimulate sperm production. But if you're getting it externally, it can suppress it. Breast or prostate cancer, I know the American Urology or Urologic Society has their own guidelines for that, but if I have a person that comes to me that has prostate cancer, I always ask the urologist first because I don't feel comfortable with that. But if you're considering starting it and their PSA is greater than 4 or greater than 3 in those high risk patients, do not start it. They need a urology evaluation first. If the hematocrit at baseline is greater than 48, you really want to reassess, check it again, basically. And hematocrit can also be elevated in people that have untreated sleep apnea. So there's kind of twofold for the sleep apnea. If they have untreated sleep apnea, starting them on testosterone can make that worse. Also, if you have untreated sleep apnea, your body thinks that it's in a low oxygen state, and so it tries to make more red blood cells. So if their hematocrit is already high, I would evaluate them for that as well. Untreated heart failure, if they've had an MI or a stroke in the last 6 months, that's contraindicated. And then certainly if they have any clotting disorders, that needs assessed first because there's some slight increased risk of blood clots with testosterone therapy. And then the last couple of slides I have are a little bit more tedious, but these are just risks of testosterone therapy. I would say the big thing is, erythrocytosis. So I usually explain that to patients. I say it can make your blood too thick. So it can put you at risk for heart attacks, strokes, and that's why it's important to monitor those labs. If the hematocrit goes above 54, you have to hold testosterone. They might need a blood draw. If I were going to try to restart them on testosterone, it would be at a much lower dose, and I would really be watching that number. And then as far as the cardiovascular, there's no consistent data between, major adverse coronary risks or events and testosterone therapy. but some studies will report a negative relationship. So, you really need to be assessing, do they really need this if they have horrible cardiovascular disease? And I think it's always reasonable to reach out to their cardiologist and check with them as well. Blood clot, there may be some, a lot of this data is back and forth, but I do the usual things. If I'm going to start someone on hormone therapy, I talk with them about if they're smoking and they take testosterone, that increases their risk for a clot. And I tell them basically it's really important to monitor your labs. If the testosterone is too high, it can put you at risk for a blood clot. I know we talked a little bit about the prostate and fertility, so I won't read that out again. But usually the consideration would be to send them for sperm banking if they are interested in fertility. Anybody have any questions? I guess I can.
Yes, I do. I've kind of got a couple of gentlemen who have been on testosterone replacement therapy for quite a while. At what point do you stop? Is there an age cutoff?
That's a good question. So our Endocrine Society guidelines say really you should assess it at age 65 or higher. I find that they want to continue it, but the older, just like in females where we go through menopause, we're not making any estrogen anymore. Well, I mean, the same doesn't hold true for a male, but their testosterone concentrations are going to drop with age. And so I tell them, it can drop over time. We could either reduce your dose, because it's really difficult to talk them into stopping it. And you can tell them, I don't remember the exact verbiage, but of how they list it in their recommendation, but it's really just kind of reassessing whether they need it or not. But that's always a really difficult discussion. So I feel like that wasn't a great answer, but
there may not be a great answer.
Yeah, because I'll talk to them about it and they're like, well, I mean, I just got so run down without it. And so you could always just talk with them about maybe even trying to reduce the dose and see how they feel. But, as far as continuing it, I think it's just benefit versus risk. And if their quality of life is better, then I would give them the lowest possible dose to make them feel good. And then I don't think there's any harm really in continuing it at that point.
Okay. Do you try a little harder to talk the older gentleman into getting the annual PSAs, or is there some guideline for that? I mean, we talked to them about prostate screening, but then at 75 or so, we quit that. So
yeah. I don't have a lot of people that are at that age cutoff at the moment in time. I probably would still screen them. You know how sometimes we'll stop the mammograms, but if they have a longer than 10-year expected lifespan, then we'll sometimes continue it. I'd probably treat it the same way.
Okay, thank you.
You're welcome. I feel like I flew through the testosterone formulations, but I wanted to get through them all. But honestly, with the ones that I use, intramuscular, transdermal, and then I do like the subcutaneous. So I just don't use the oral formulations yet.
No, you did a wonderful job. Thank you so
Thank
very
you.
much. Absolutely.
Thank
Does
you.
anybody else have any questions, or please do just email them our way if you do and they weren't covered today. We'd be happy to reach out to Dr. Turner if in that instance. But I only have one announcement. The next time we'll meet is April 26th with ADA guidelines. So really appreciate everything today. Great discussion, and you have a wonderful rest of your week.
Thank you.